A very warm good evening to one and all who are in various platforms, from the Docplexes, the IAGS channel, and the Facebook channels of the IAGS Connect. It's been a wonderful evening for all of us, and we wish you all a pleasant good evening to you who have been with us in India, and people in the Latin America, we wish you good morning, and people at various zones in their respective time wishes. I'm happy to host yet another important edition of the IGS Prime Time, showcasing the best of the talents in the field of minimally invasive surgery in various specialties. May I have the honor of inviting our president, the Indian Association of Gastrointestinal Endoscopic Surgeons, Professor Sunil Papat, an ardent leader, a very kind-hearted person who have been directing us various, I would say, one of the best COVID relief program any association can do in this part of the world. He's been spearheading all the efforts. And on the professional side, Professor Sunil Papat is a foregut surgeon. He has a special interest on all aspects of benign foregut surgery. And he has hosted the fellowship programs, advanced fellowship programs, and the national conferences of the IAGS and other important societal meetings. May I have the honor of inviting Professor Sunil Papat, the president of the IAGS, to tell us a few words. Over to you, sir.
Thank you. Karagave, Professor Sunil Papat is also a very accomplished colorectal surgeon. He has got a huge series of total colectomies and pouches for ulcerative colitis.
Absolutely, sir. Absolutely. Please.
Thank you. Thank you for your kind words, Dr. Kanagvel and Professor Ramesh. Good evening, friends, and good morning to our Latin American friends in Venezuela, and good afternoon to our European colleagues. Welcome to yet another exciting event of IAGS Prime Time. IAGS, an organization of 8,000 laparoscopic surgeons, has been at the forefront of academics since so many years. IAGS went to virtual academy since last 1.5 years because of the COVID pandemic. And on the virtual front, IAGS has delivered many programs. One of the best program is IAGS Prime Time. Today we are having 22nd episode of IAGS Prime Time. Today we are discussing two very important topics by two leading faculties from different parts of the world. I'm very pleased to welcome Professor Ricardo Escalante from Venezuela, who is a leading colorectal surgeon and professor. He has tremendous amount of publications in various fields of surgery, and one of his pet subject is rectal trauma management. I was, when Dr. Kanagvel asked me that can we invite Professor Ricardo Escalante, I was actually thrilled that such a leading faculty coming to IAGS Prime Time. It's an honor for us to have you, sir. Welcome to IAGS.
Thank you.
In the second part of today's program, we have a leading figure in the minimal access and gastrointestinal surgery in all parts of GI surgery. Everybody knows Professor Ramesh Ardhanari. He's a professor of GI and laparoscopic surgery in Madurai Medical College and teacher to thousands of surgeons. Professor Ramesh Ardhanari is also past president of PAMASI and has, to his credit, many more publications and chapters. Professor Ramesh Ardhanari is going to speak on rectal prolapse management, because there have been so many discussions and debates in the management of rectal prolapse for last 10 years, and there is no better person to throw a light on this subject than Professor Ramesh Ardhanari. As my dear colleague Dr. Kanagvel mentioned, IAGS has been at the best of its philanthropic activity in this COVID pandemic time. All the IAGS executive members and friends of IAGS and IAGS members contributed to IAGS COVID Relief Fund and COVID Relief distribution efforts. Because of that, we have been able to distribute various items of need to all the parts of the country, starting from Jammu and Kashmir to Kanyakumari and from Ahmedabad to Assam. IGAS led from the front in this COVID pandemic, and thankfully now we are at the fag end of this second wave, and hopefully we may not have third wave, or we can delay it as much as possible. So maximum number of population is vaccinated and the impact of the wave can be really minimal. Without much ado, I welcome you once again with our dignified executive body members, Dr. Subhash Agarwal and Dr. Suviraj John. And I hand over the mic to Dr. Kanagwal to take the program further. Thank you.
Thank you, Mr. President. Thank you for encouraging us with more academics and more intense academics by the week. Now, may I have the honor of introducing the first moderator, none other than our long-term committed teacher, Dr. Subhash Agarwal. He has been instrumental from the beginning of the inception of the IAGS and has been faculty all through from the time FAGS program and FLS program started. And he has been faculty across various minimal access platforms, and he's been an ardent teacher and right now heads the laparoscopic and minimally invasive surgery at the Sri Balaji Action Hospital at New Delhi. Professor Dr. Subhash Agarwal has been kind and has been very willingly accepted to the request to moderate this session. And I am sure Dr. Subhash Agarwal will host the next 45 minutes the best possible way. Dr. Subhash Agarwal, please.
Good evening. Can you hear me?
Yes.
Yeah. Good evening to our friends in India and good morning to our friends in Venezuela. So the first talk is on management of the rectal injury by
Subhash, you are not audible.
No, his bandwidth is low. That's what it is saying.
Ricardo is
You're not audible.
No, his bandwidth is low, so he's not coming.
University of Venezuela and both.
Okay. So in the meantime, I will take the honors of introducing Professor Ricardo. Then Subhash sir can rejoin again. Professor Ricardo has been an eminent teacher, surgeon first, and then minimally invasive surgeon. And then he has been instrumental, and his passion has been on various minimally invasive surgery. But then he took colorectal surgery as his preliminary specialization, and he has held various positions across the global societies. Right now, he is the board member of the International Society of the University Colorectal Surgeons across the globe, which is a global integrating unit of all the colorectal surgery societies across the globe. Professor Ricardo has been the immediate past president of the Venezuelan Society of Coloproctology, and he right now heads the minimally invasive and general surgery department in the University Hospital at Caracas. And then more so, he has been instrumental in hosting and creating various colorectal programs across the globe. Right now, he is in the editorial board of the Journal for the ISUSCRS, and he's been a friend of our country in various colorectal panels and various colorectal teaching programs. A friend, a kind person who immediately accepted our invitation in spite of his busy schedule. Ladies and gentlemen, may I now have the honor of inviting Professor Ricardo to start sharing his presentation. Over to you, Professor Ricardo. Sir, Professor Ricardo, please unmute yourself.
Yes, I know it. Thank you very much. I'm going to begin to share my screen.
We are able to see your screen, Professor. You're good to go, Professor.
Yes. I'm checking.
I think Dr. Subhash Agarwal is back. Sir, are you okay? Are you comfortable?
Could I begin?
Yes, sir. Please go ahead, sir.
Okay. First of all, I would like to thank you for this kind invitation. It's a pleasure to share time with colleagues and friends from India, even by internet. The only disadvantage of this tool is that I cannot taste your excellent dishes. This is a painting of the Waterloo battle, called the mother of the battles. When we talk about rectal trauma, it's necessary to talk about war. And why? The main reason is that our main knowledge and evolution about colorectal trauma came from different wars on the world. The first information that we have about rectal trauma comes from the American Civil War. The time for translation from the front line to hospital was around 2 to 3 days. No surgical alternatives was given for those patients, and the mortality was over 95%. During the First World War, the situation began to change. Military surgeons repaired primarily the rectal wounds, and mortality began to decrease. It was around 60 to 90%. At Second World War, the Major General G, a British surgeon, established that in colorectal lesions should be done cephalostomy, and here we can see how the rate of mortality is less. Then, what happened at the upcoming wars? Surgeons found that infection and abscess was the main complication and mortality cause in extraperitoneal lesions. For this reason, during Korean War, they began to drain these wounds. Here, you can see how the mortality decreased. During Vietnam conflict, American forces began to use helicopters for evacuation, and the time for transfer diminished dramatically. In that time was established the management of 4D, fecal diversion, distal washout, presacal drainage, and direct repair. Here you can see how the mortality decreased until 13 to 15%. During Yugoslavia war, time of evacuation to main hospital was around 30 minutes. The protocol of advanced trauma support was very clear, and the concept of damage control was begun to use. Remember, when I began to talk, the mortality during the American Civil War was more than 95%. During this conflict, the Yugoslavian war, we can see how it improved until 8%. As I told you before, experience and change in colorectal trauma come from military experience, but we shouldn't forget that causes are different. In combat, they use high-velocity bullets with more power than gunshots at civilian life. At urban hospital, rectal lesion by blunt or penetrating wrists, blunt and penetrating lesions are less frequent. This, we can look two papers, very interesting and important. Both collect the wide experience about rectal trauma. The first one reviewed more than 900 cases in military hospital during the Iraq War. And the second one show more than 700 cases in trauma centers at the United States. The first one was published in 2012, and the second one was published in 2018. If you are interested in this topic, don't forget to check these papers. Okay, let's begin to talk about injuries. Anatomically, anorectal lesions are divided in 3 levels: intraperitoneal, extraperitoneal, and perineal. The management of intraperitoneal rectal wounds is similar to wounds of the colon, and perineal lesions has a special consideration and is a topic for another talk. During this talk, we are going to consider only extraperitoneal lesions. Please pay attention to this design. In terms of surgical approach, extraperitoneal rectal lesions are divided in 2 levels: the proximal and the distal extraperitoneal rectum. On 1982, Robertson classified the causes of rectal injuries in 6 topics. They are very important to know because are necessary to establish the initial approach and their management. Foreign bodies for sexual assaults or ratification is an issue. Many years ago wasn't common, but nowadays we receive more cases with this issue. In its consequences and management needs another presentations. When we receive this kind of lesion at emergency room, the first step is to give them an adequate support for trauma, well known as ATLS. Suspicion is the key for colorectal trauma. For it is necessary complete physical examination, which include abdomen, pelvis, perineal, and genitals. With digital rectal examination, we could obtain important information as anal sphincter tone, detection of rectal foreign body, gastrointestinal bleeding, and potential fracture of the pelvic bones. With the rigid proctoscope, we could have an idea about the level and degree of the lesions. If the patient is stable, we should search for more information in single X-ray fracture of the pelvis, sacrum, or other walls. In situ ureterography, extravasation of contrast to the bladder and urethra. With water-soluble enema, we can find extravasation from the rectum. In this both CT scan, we can observe how the contrast goes from the rectum to the bladder. And at the other CT scan, we can look some fractures of the sacrum, air, and liquid around the perirectal space. And here we can see how the rectal wall is thick. Most of the patients have signs of peritonitis, even with extraperitoneal lesion. For each suspicious should be a rule. If we do a proper digital exam and proctoscope, we could have an idea of the extent of the injury in more than 80%. Management of lesion depends on the extent of them. International, we have 2 classifications. The first one was done by Flynn in 1981, and he pointed 3 grades. The more single, the grade 1, they describe an isolated injury until the grade 3, where we can find a devascularization and a heavy contamination. 10 years later, Moore published this classification. In my personal opinion, Moore classification is better from practical viewpoint. By other hand, Moore classification gives us a score of some trauma protocol, as you can see right here. There are many controversial points about management of rectal wounds because every surgeon has different point of view with well-supported papers and experience. The most important issues of controversy are how to manage the destructive wounds, the controversy about if primary rectal repair or not, ostomy or not, what could we do about presacral drainage, rectal washout, and recently the use of laparoscopy. About surgical alternatives, there are many. The right one depends on the case. No one case is similar to other case. As I told you before, the controversy is between the primary repair, do it or not, loop colostomy or loop ileostomy, when to do the Hartmann procedure, and what about the proximal diverting colostomy without suture the perforations. What about the presacral drainage? The presacral drainage should be used in selected cases, different than the past, when the surgeon used as a routine, when we should and when we shouldn't use. In this slide, we can look at recommendations where not to use. For example, not use when the wounds are at the anterior part of the distal rectum, when the extraperitoneal wounds has been repaired effectively, when we have a massive extraperitoneal lesion and we do an ostomy, and we have this important study of Gonzalez. Gonzalez report that presacral drains without rectal wash did not reduce the rate of infection complication. This is the only randomized study published about presacral drain. And the other point, the second, when we should drain the presacral sprain. We should drain the presacral sprain when the wound is extraperitoneal and posterior, when we didn't explore and we didn't find the hole of the wound. In other case, when the injury, the sacral injury is large with a lot of spillage like bones, bullets, and other foreign bodies. And the other points to remember is that we should use the presacral, when we use the presacral drain, we should use it for a short time. The situation about distal rectal washout is different. This technique should be banned, should be abolished from our practice. All the recent papers support that rectal washout has more disadvantage than advantage. We can look that it was associated with threefold increase in abdominal complication, and sometimes the washout liquefy the rectal content and facilitate the fecal spillage. The American College of Surgeons recommends not to use the distal rectal wash. What about the laparoscopy? In our minds, we have the idea that laparotomy is the gold standard for the management of colorectal lesion. The use of laparoscopy is controversial, but every day we find papers which support the use of laparoscopy on abdominal trauma. In this paper from South Africa, they published an experience of 20 cases with extraperitoneal rectal lesions. They didn't repair the lesion, they did a diverting sigmoid loop colostomy and avoid laparotomy in all of the cases. They didn't have mortality, and as complication, they reported only 2 rectocutaneous fistula, which closed spontaneously. They pointed that they repaired the extraperitoneal rectal injuries only in 3 occasions, when they are really accessible with minimal dissection, when the rectal wound is exposed during dissection, and the repair associated injuries like big vessels, vagina, or the third one is when they have genitourinary injuries associated and they repairs during the surgery. Sometimes in our life, we could face an extreme case which need a special effort, in which case, for example, complex anorectal injuries associated with pelvic hemorrhage and open pelvic fracture is a new scenario to work. It's very complex, and in this case, it's necessary to pack the pelvic area, and in this moment, it's not recommended to do some resection. The best move to this situation is to pack the pelvis with laparotomy pads control to control the hemorrhage and attempt to control the contamination. After recovery and resuscitation in intensive care, we could go back to the operating room with a clear mind and the support of the multidisciplinary team. In this moment, we can go to the operating room, clean the area, and in rare cases with devastating anorectal injuries, an early abdominal perineal resection could be done. Is the only option to control the massive bleeding and to prevent the severe postoperative sepsis. In my public and private practice, I never have seen or I never have done an abdominal perineal resection for rectal trauma. To solve this kind of cases, we don't need surgeon, we need superheroes. It's a big trauma with a big hole with perineal and rectal trauma. You can look right here, the scrotum, and the management of this situation is very, very difficult. Just to finish, I would like to give you some practical tips. When we go to the operating room, the patient should be placed on the operating table in lithotomy position. The idea is to do the rigid sigmoidoscopy before surgery. But if the patient is unstable, we could avoid to do the sigmoidoscopy in this moment. The laparotomy, the exploratory laparotomy is mandatory in this moment. Low rectal injuries may be repaired transanally, and high rectal injuries could be necessary to access transperitoneal. What about when we are at the operating room? In the mid-rectal injuries, when the exposure is difficult, especially in males with a narrow pelvic inlet, it's necessary to do a proximal colostomy, and it's not necessary to repair the rectal perforation. It's a controversy because sometimes the surgeon insists to repair the rectal perforation. When we repair the rectal wounds and we have some genitourinary injuries, it's necessary to separate the rectum from the bladder, from the urethra, because in order to the idea is to reduce the risk of vascular graft infection and the formation of rectovesical fistula. The rectovesical or rectal urethra fistula is very common as a complication. Which other tips may I give you? Ostomy. It's better to perform a loop ostomy than a colostomy because it's easy to close. The time for closing recommended is after 6 to 8 weeks, and prophylactic antibiotics should be mandatory. The prophylactic antibiotic should be used preoperative during 24 hours. Finally, what is the idea to take this home message? Rectal trauma is not frequent. the majority of rectal injuries occurs secondary in our hospital, secondary to firearms. Stab wounds and impalements are rare. The current treatment for rectal injuries involve a combination of the techniques that we have learned from military hospital. It's necessary to manage the rectal injuries with an interdisciplinary team, which include general surgeon, colorectal surgeon, urologist, orthopedist, vascular surgeon, and stomach therapist. Surgical treatment should be individualized. It's not a receipt. It's not a rigid protocol. Each patient requires different techniques, different management, and different approach. I would like to close my talk with this picture. This is the Angel Falls in Venezuela. This is the highest waterfall in the world, almost 1,000 meters. And please, thank you very much again for this kind invitation and for your attention. Thank you very much.
Professor Subhash Agarwal, you are with us?
Thank you, Ricardo. There are few questions. One is, what happens if rectal prolapse is left untreated?
What happened with the rectal prolapse?
Rectal
Is
prolapse
left
will discuss.
untreated.
Subhash will discuss afterwards. Rectal prolapse.
Okay.
Just yeah.
Okay. How to deal with post-traumatic sphincter injury?
Well, when we find a perineal lesion, perineal injury, the first point to evaluate is the tone of the sphincter, okay? Because usually when the lesion comes from, for example, from stabs or from traumatic issue, it's necessary to check how is the function of the sphincter. The first one is to check how are the sphincter. By the digital exams, we can check it. Is the first step. And if we have some suspicion, we have to try to find how large, how big is the lesion. The first step in these cases is to solve the emergency, to solve the situation. But at the operating room, we can check how is the sphincter. If the lesion is a small lesion, we can try to repair, but only if the lesion is small. If we have big lesion, we can leave the repair for the second surgery, not at the first surgery, because at the emergency room or the operating room in emergency, the idea is to solve the emergency. The repair of the sphincter is a secondary approach.
Thinking, what about the blunt trauma when there is a lot of hematoma in the perineum and the injuries are missed? How you manage such injuries?
Yes, hematoma at the perineal area should be drained. But first we have to check how is the rectal wall, how is the distal rectal wall, because probably the origin of this hematoma is a lesion of the rectal, not the lesion of the vessels around the rectum.
I think you have dealt with every aspect of the rectal injury beautifully, both traumatic as well as most common is whether it's a penetrating gunshot or pellets injury. Yeah. Any other query from anybody? I don't see any other question here. So if you have any, you are most welcome.
I could see Dr. Ramesh Ardhanari's hand going up. Sir, please unmute yourself, sir. Please go ahead, sir.
Yeah. See, in India, the situation is different. We don't see gunshot wounds because guns are restricted in India. So we don't see much. And when we see them, they're usually chest or head or abdomen and not really in the rectum. What we see is south, especially in Madurai, is that we have the season when we have this, Jallikattu, bullfighting. And whenever the bull is being caught, the bullfighters are trying to run away from it. And so it hooks its head down and the horn hits from below, causing rectal and perineal injury. And we get that at least 4 or 5 cases every time this festival goes on. The rest of the time we get it from road traffic accidents, when they have had either they have fallen on, been impaled on some sharp rock or rod, or the tractor or bus has run over the pelvis, fracturing the pelvis, injuring bladder, rectum, everything. So,
but there are few cases we also get of the sexual abuse too.
Yeah,
we have seen quite
not too many in this side of the world.
Not too common,
but we are always defensive as far as rectal injuries are concerned. Indians produce a lot of feces because they eat a lot of fiber in their diet. Therefore, the contamination is heavy and they will die. So we are aggressive in doing colostomies. So we do recommend to our postgraduates who are usually on duty that rectal injuries, whatever will happen, you do a colostomy. We will close it after 3 months once they become all right. And most of the patients recover with a colostomy. If you don't do a colostomy, we have lost some patients because there are some doctors who don't want to do a colostomy, and we have seen the results of those patients. So we do that quite often.
I agree.
Thank you, Dr. Ramesh, sir. I now have the honor of inviting the president to give his comments.
I think, Ramesh, you are right. We also do colostomy. We are getting mostly post-trauma rectal injury cases. And, colostomy is one kind of lifeline in such patients.
Yes, it is. It is.
So, Ricardo, excellent lecture. Enjoyed it thoroughly. One question for you is regarding presacral drain. What do you mean by presacral drain and how you put it, and what do you use, a corrugated drain or a tube drain?
Many years ago, we used as a routine the presacral drain. It was a routine, but now we use very, very rare. When we use a drain, we prefer to use an active drain, and we leave it for 2, maximum 3 days, no more than 3 days. Because if the risk is that we use the drain for more than 3 days, we can establish a fistula and we can bring complication with the genitourinary tract.
Yeah. So when you put a presacral drain, you put it perineally or transperitoneal?
Perineal.
Perineal. And
Perineal.
You bring it out posterior to rectum?
Posterior
to anal canal?
Posterior, and we take
through
out
the same wound?
No, we don't use the same wound. No, we didn't.
Yeah.
We didn't.
So thank you so much for an excellent lecture and excellent take-home message. Excellent moderation, Dr. Subhash. Thank you for moderating this session. And before we move to the second lecture, friends, we are already doing online FIA-GES, that is the fellowship in essential laparoscopic surgery, and EFIA-GES, that is endoscopic FIA-GES. And also we are starting Pulse Oncology in a few days' time. That is a fellowship of advanced laparoscopic surgery in oncology surgery. So I request all the IGS members to log on to igs.in and register for respective fellowship courses. I invite Kanagwal to go for the second lecture.
Thank you, Mr. President. I thank Professor Ricardo for sharing his valuable time amidst a working day in Venezuela, for contributing his experience in the management of rectal trauma to our fraternity. And I thank all the friends across the globe, in India and across the globe, especially Latin American surgical colleagues, for joining us in this event. Thank you, Professor Ricardo. IAGS looks forward for more relationship academically to strengthen the relationship between the country and Latin American colleagues. Thank you for joining us. Looking forward for more interaction. Thank you. Friends, ladies and gentlemen, we move on to the next second part. Professor Ricardo, if you have academic commitments, I feel free to leave. Otherwise, Dr. Ramesh is one of the very brilliant speaker. You can definitely spend your valuable time to visit to him as well. Thank you. Now, I have the honor of inviting Dr. Suviraj. Dr. Suviraj is, I would say, a dynamic young surgeon, has been very brilliant on both on academic and social grounds. Dr. Suviraj is the lead architect of the IAGS Connect app, which is integrating the entire IAGS activities to one app. And I'm sure all of you will be able to enjoy the best of the association apps have you ever seen, shortly going to be released. It is in the beta testing form. Dr. Suviraj is a dynamic laparoscopic surgeon, has been there associated with IAGS for a very long time, and has been instrumental in hosting FAGS and FALS program and other programs in Delhi and surroundings, and has been always a willing participant as a faculty for various academic activities of IAGS. He right now is the minimally invasive and robotic surgeon at the Sir Gangaram Hospital, and coming from the background of army and military background, is known for his discipline, and is known for his most recent and most evidence-based talks, which he has been known for it. Ladies and gentlemen, may I have the honor of inviting Dr. Suviraj to take over the next 45 minutes, host the program, introduce the next speaker, Professor Ramesh Ardhanari, to you. Dr. Suviraj, over to you, please.
Thank you, Dr. Kadagwale. Big salute to Professor Sunil Popat, President IAGS, and to Dr. Subhash Agarwal, my mentor, and Dr. Ishramurthy, who's here. Ramesh Ardhanari, it's my singular and unique honor this evening to introduce you to our esteemed panel as well as the audience around the globe. You have been a mentor to many of us over the last 2 to 3 decades. I first listened to you way back in September 1998, and that presentation is still live and vivid in my memory. And that's because you have always maintained a very lucid and categorical approach to your teaching. This has enabled generations of surgeons to be excellent students and now practicing surgeons. And we look forward to the same approach this evening to the current management of rectal prolapse. A brief word of introduction about you. You're currently the chair of the Department of Surgical Gastroenterology and Department of Surgery at Meenakshi Mission Hospital and Research Center, Madurai in South India. You are also the chair of the postdoctoral minimal access and DNB super specialty surgical gastroenterology courses at the Institute. Look forward to this along with the others to your presentation. Rectal prolapse, a brief word of introduction, is an upcoming surgical challenge. As surgeons, both new and veteran, like to have a recurrence-free repair as well as promise and give the patient a fantastic functional outcome, both in terms of constipation and incontinence, along with other pelvic organ prolapse and dysfunction issues. Over to you, sir, Dr. Ramesh Ardhanari.
Good evening to everybody. Thank you, Suviraj, for the kind introduction. I will move straight on to my talk. So let me open my PowerPoint, and then I will share it with you on the
We are able to see your slides, sir.
Yeah, I'm trying to bring it to full screen.
Yes, sir. You'll be playing the video separately, sir?
Yeah, video separately.
Okay, done.
Yeah, can you see the full screen video?
Yes, sir, you are good to go, sir. Please carry on.
Good. Yeah. So I'm going to talk about rectal prolapse today. And before I come to the topic as such, I am going to talk about the complete rectal prolapse that we normally see in adults, but we occasionally see in children. I am not going to talk about the mucosal prolapse or the other type of prolapses that we see in children, because I think that's a totally different topic, requires a different approach. So I'm not going to go on to that. Now, rectal prolapse is characterized by some findings. The first is that every patient with rectal prolapse has an abnormally deep pouch of Douglas, or in the male, an abnormally deep rectovesical pouch, because as the rectum has gone down, it has taken the pouch down. There will be a laxity and an atonic condition in the muscles of the pelvic floor and anal canal. The internal and external sphincters are weak. So many of these patients are, in the presence of the prolapse, incontinent. At least they soil their clothes. And they will, because the pudendal nerves get pulled with the rectum, they develop pudendal neuropathy, which worsens the sphincter's performance. And the normal fixation of the rectum is lacking. So the thing prolapses because it is not fixed as it is normally fixed. So this is the background which we have. In literature, it is said that women have more rectal prolapse than men. In India, however, in my practice, I have operated 90% of my patients on men. I don't know whether the women don't come, or because women generally tend to have not a full prolapse but a rectocele. And so they go to the gynecologist who do a pelvic floor repair and do it very well. Some of these gynecologists do it so well that the cases don't come to us maybe. That is why we don't see them. So we only see them if they have a complete rectal prolapse, but somehow that in my practice, it is very low. 90% of my patients are men. Some are, of course, women. It affects extremes of age. So elderly people have more rectal prolapse. And of course, children have. And about the children, I'm not going to talk. Almost 70 to 80% of the patients who have rectal prolapse will have associated incontinence. This incontinence is because the prolapse acts as a dilator of the anal canal. So every time it prolapses, it is dilating the anal canal, and every day it prolapses, every time the patient goes stool. So you get multiple times it is stretched. The sphincters are stretched, and this is like doing a manual anal dilatation, and they get incontinence. The history of constipation is very important to take in the patient. The history will come depending on how seriously and diligently you question the patient. And the constipation is not the constipation at the time of the rectal prolapse, but what was it in the past. And we find that up to about 30% in our patients have significant constipation in the past. And even now, they have soiling and incontinence, but they still don't pass motion freely. And they like to take a laxative. So you should know this, because as I'm going to show you later, the treatment of the disease, constipation plays a big role in deciding what we are going to do. Solitary rectal ulcer syndrome may be associated because some of them can't evacuate. So they put their finger and then that hurts the mucosa, and then that can cause. So what is the aim of treatment in a patient with rectal prolapse? The diagnosis is easy. All you require to do in the modern era is ask the patient, if I send you to the toilet now, will it come out? He'll say yes. So you send him to the toilet, send one of your postgraduates with a mobile camera, take a photograph and bring it and show it to you, and you'll know that he's got a complete rectal prolapse. Of course, I'm not talking of the internal prolapse, which, as I'll show you, may require an MRI a cine MRI or a cine radiography to diagnose. And that can also be a complicated problem. So so the aim of the treatment is to control the prolapse. So this is the most important. The patient must not have the rectum coming out. So he wants you to make him free of this. You must restore continence. And here I would like to stress that there are some people who I've heard their talks, who say that when the patient is incontinent, they control the prolapse with a prolapse operation, and then they do a graciloplasty or something at the same sitting for the incontinence. I think it is wrong. You see, if you reduce the prolapse and prevent the rectum from coming, 90% of patients usually get sorted from their incontinence in about 3 months. So, if a patient has incontinence, you should do only the rectal prolapse repair, and most of the time it will settle down the continence problem. I have never had to do a graciloplasty for continence in a rectal prolapse patient in my life. They have always settled down. The only patients I've had to do are the ones who have suffered severe rectal injury due to birth trauma or one of these perineal injuries which has caused severe rupture of the muscles and they can't be repaired. Otherwise, for rectal prolapse, I've never done it. I restore the prolapse to normal and they become all right, they become continent. And we should try to prevent the constipation the patient is having before surgery, because if he has constipation and he again strains, the rectum may come out, especially in the early post-operative period. So, very important that when you operate these patients, in the early post-operative period, give them good laxatives and tell them, sit and tell them, don't worry if you don't pass motion, there is no urgency. Indians are obsessed with passing motion. Please remember that. If they don't pass motion, they think something is grossly wrong. So you have to teach them that it's not important, at least for the first 6 weeks. Once 6 weeks pass, the rectum gets fixed, then even if they strain, nothing will happen. But in that 6 weeks, before it gets fixed, if they strain, the rectum may come out and then the whole prolapse will again come out. So the principles of therapy are two. One is resection or plication of the redundant bowel. So either you pull the redundant bowel and then fix it, or you do a resection, shorten the length and then fix it. The second principle is that the rectum is fixed to the sacrum. As I said, in the pathology, one of the things that you find is that the loss of fixation to the sacrum is preeminent. And fixation to the sacrum is a very important thing. Normal fibrosis will fix it. But I'm going to show you some data. Fibrosis alone will fix it in 90%. But if you add something to support it till the fibrosis comes, it increases to about 98% success. So for that 8%, you must use some method of fixing the rectum in the immediate post-op period so that it will not again come out. As I said, in incontinent patients, the patellar sphincter begins to retain the tone in 1 month and is full continence in 2 to 3 months. The procedures for rectal prolapse can be abdominal procedures or it can be perineal procedures. The abdominal procedures, there are 4 commonly done procedures, 3 procedures, and the 4th is a different approach to doing the same 3 procedures. One is a suture rectopexy, prosthetic or mesh rectopexy, resection with rectopexy, and all of these 3 can be done by open surgery or can be done by laparoscopic. So you can do laparoscopic suture rectopexy, laparoscopic mesh rectopexy, laparoscopic resection, and rectopexy. Then there are a number of perineal procedures. We'll come to that as we go. The first thing is that we have to choose whether we should choose an abdominal or a perineal procedure. Remember that the recurrence in most series has shown that the perineal procedures have a higher recurrence rate. Though we feel that perineal procedures should be safer, studies show that they have equal morbidity and mortality. In elderly patients who are unfit for general anesthesia, unfit for laparoscopy, perhaps a perineal approach is better. So, should you do a rectopexy? This is a question that many senior professors used to say, you just go and mobilize the rectum and then leave it. The prolapse will heal. Now that happens because once you mobilize your raw area and fibrosis occurs, and the rectum gets fixated to the sacrum, which it was not before the procedure. But in Italy, they did a large multi-center RCT, and they found that if you don't do rectopexy, there's an 8.6% recurrence. Whereas if you did rectopexy, it was 1.5%. Although the no rectopexy group had more resections. So they had resections, but they had more recurrence. So the advice is currently that if you do rectal mobilization, you should in some manner fix the rectum to the sacrum. It's a temporary necessity. After about 6 weeks, once the sacrum is fixed to the rectum, these sutures will no longer matter. But for that initial period, that is when the recurrence occurs, you should fix the rectum. So rectopexy should be performed. So elderly patient not fit for an abdominal approach should have a perineal operation. There are young patients, male patients, who fear the risk of sexual dysfunction. And it's a true fear. Mind you that if you do anterior dissection in the abdomen, the rectum is very close to the prostate. And if you deviate a millimeter towards the prostate, you will damage the nervi erigentus. And when you do that, they will become impotent. So it's a true fear. And whenever I have a young male patient with rectal prolapse, I discuss. And I tell them that there's a percentage chance that you will become impotent. So would you like to? So the balance is that if we do a perineal procedure, he may have a higher recurrence. But I have found that most patients, when I explain to them, they choose the perineal procedure or they choose the anterior abdominal procedure without anterior dissection. So there are two ways. If you don't do anterior dissection in the abdominal phase, you won't get the nerve injury. The nerve injury occurs, the posterior nerve injury is usually bladder related. That will settle down with time. It is not that problem, but anterior one is impotence which doesn't settle down. So you always do inform them, and if they are very particular about the impotence, do either an abdominal procedure with no anterior dissection. But if the prolapse is big, then you can't do an abdominal procedure without anterior dissection, because the prolapse will invariably come back. So my principle is that if the prolapse is less than 5 centimeters from the anal verge, then I will offer them a rectopexy with no anterior mobilization. But if it's more than 5 centimeters, I will tell them that I will do a perineal operation. The operation will either be a Altemeyer's procedure or a rectosigmoidectomy perineally done, and we will come to that later. If you have a procedentia, a rectal prolapse has come out, not going in big rectum, then I think the best procedure is the perineal approach, the rectosigmoidectomy, and as I will show you, it's a very simple operation. So in the perineal type, some people usually use the jackknife position. In the prone position is much easier to do the rectal operation that way. They prefer a regional anesthesia, and you like to have self-retaining. Now this is the operation of Altemeyer, which is nothing but perineal proctosigmoidectomy. Now what you have is, and this is what we do for these emergency cases that come and the prolapse doesn't go back in. We try to conservative management, like putting raw sugar on the prolapse. The sugar absorbs the fluid, and the prolapse can shrink. If it shrinks and retracts, then we keep them in a head-low position for 2 days, and then slowly try to get the swelling off, and then do a abdominal procedure, because this swelling will last a long time. And with a swollen rectum, doing the abdominal procedure is also not easy. So we have now come to the conclusion that the simplest thing to do is to do the Altemeyer's operation. And I tell you, those of you who have not done it or not seen it should do it. You don't need to go anywhere to learn it. Such a simple operation. you have the prolapsing rectum out. So what you have basically is a wall of the sigmoid and a wall of the rectum. So close to the anal verge, anteriorly you cut about an inch till you've gone through both the things, and you see the sigmoid mucosa and the rectal mucosa. Immediately take 2 stitches. I use 20 Vicryl. Then I cut a little bit more on either side, put 2 more stitches. Like that we go circumferentially, and the specimen is delivered. When it is delivered and all the stay sutures are held outside, it looks like, arey, ye to prolapse karega. It will come back again out. Just release the sutures. Everything will retract into the abdomen. There will be nothing seen, and these patients do wonderfully well. Leaks are very uncommon because we don't touch the vascular supply, and they recover very smoothly. We have done in this year alone about 3 of these procedures. Every year we do about 2 to 3 now. I never used to do this before, but now I started doing more, and I find that it's a wonderful operation, especially for the emergency. This is an operation with which I have, with which I have the anal mucosectomy and muscular plication operation, which I have no personal experience. I have never done it. So all I know is that you have the prolapsed rectum outside. You make a circumferential incision on the mucosa at the level of the anus verge. You strip that mucosa from there completely off the muscle, and then re-anastomose the distalmost mucosa with the proximal mucosa. It's like an Altomeyer, but you don't divide the muscle of the prolapsed rectum. So to me, I always feel that will it cost a little bit more recurrence than Altomeyers, because you have not cut the muscle and the excess muscle, you have plicated it. So will the plications give way and then it will again collapse? I don't know, but I have no experience of this operation. But there are some who have done it and they swear by it, and they say it's a wonderful procedure. Of course, the Thiersch is an age-old procedure. We no longer do it for any patients, because unless they are 90, 95, they have a prolapse, they're going to live for only 4 to 6 weeks or 8 weeks, they have terminal cancer, the prolapse is troubling them, then a Thiersch can be done, but it's not a permanent answer. The abdominal procedures are the ones that are done commonly, most patients. And the operation of choice, which I recommend, is the sutured rectomy. It virtually has no mortality. Recurrence is about 0 to 3% in various studies. There is improvement in incontinence. Usually, a pre-existing constipation doesn't worsen, but it may not improve with a sutured rectopexy. And in the male, it has a better outcome than in the female. Why? We don't know. So the principle is, as you see in this photograph, the rectum is mobilized and brought into a straight line. So you completely mobilized it. So the rectum, which was lying coiled in the sacrum, mobilized, put into a straight line, held up with a intestinal clamp, and you take on either side 3 bites to the presacral fascia, avoiding the presacral veins and the nerves and the ureter, because the ureter also will be closed. You take 3, 1, I usually take 1 low down at the level of the ureter, and then 2 higher, and the third one will be at the level of the sacral promontory. So I take 3 stitches on either side, usually use 2-0 bond. I'll show you a video at the end of this procedure, presentation. And this is the operation of choice for my abdominal procedures. The same operation, you mobilize the rectum, just like you would do for, we'll come to how much mobilization a little later. And instead of putting these sutures, you put a mesh posteriorly, you fix the mesh to the sacrum and fix the mesh to the rectum. Now, previously people used to use big pieces of mesh, and the mesh would completely cover 3/4 of the rectum. And then when it shrank, these patients would get terrible constipation. People have overcome that by making it into a slim T. So you have the vertical limb of the T, which goes on to the sacrum, and the 2 horizontal limbs sort of hold the rectum up at the level of the promontory. So they say there's less constipation with this. But putting a foreign body there, I have had the unpleasant job of removing a mesh through the rectum lumen with an endoscope, which was placed outside because the whole mesh had migrated into the rectum. And it was very difficult to remove, but it took me 2 hours and then only I could remove. And then there was a big hole left behind, which I closed, and then I had to do a colostomy to make sure it doesn't leak. And then the patient, I closed the colostomy later. Originally in this posterior rectopexy, Wells used Iverland sponge. We no longer use this. Now we use a mesh which can be absorbable or unabsorbable. Mortality is about 0 to 1% because meshes can get infected. Recurrence is about 0 to 6%. So this is how in the long term it was done. First, the mesh was fixed to the sacrum, and then you see almost 3/4 of the circumference of the rectum is taken. And that is why when this contracts, the patient can get constipation. There is in posterior rectopexy, you can get pelvic space sepsis if you put a foreign body. If you have done a resection along with the rectopexy, then you should never put a mesh. Let us be very clear. If you are doing a resection rectopexy, no mesh should ever be placed. You should use only sutured rectopexy. Because once you use a mesh in the phase of resection, infection and sepsis is guaranteed. Whenever we do this posterior, some people put a drain. I don't put a drain. It doesn't matter. The Ripstein procedure is an anterior sling of fascia, and you fix the fascia comes only anteriorly and fixed to the sacral promontories on either side, not fixed to the rectum. But it has a high recurrence, and we know like this, you put the mesh. It has a high recurrence, and more important, it gets constipation. You see, the rectum gets constricted between a rigid sacrum and the mesh which is undergoing fibrosis. Resection, when should you do? If there is constipation, you have to do resection rectopexy, because otherwise the constipation won't be relieved and the rectal prolapse will reform. Therefore, you must resect. The question that everybody asks is how much to resect? It's actually quite simple. You first mobilize the rectum. Then you bring the descending colon down, and when the descending colon freely reaches to the rectum without tension, but such that when you stitch, the rectum will remain straight and the descending colon will remain straight. So both of them will be straight and they'll be attached to each other without tension. All the sigmoid in between you remove. This is how I do it. It's just an eyeballing. I bring them together like this and see, and I divide on either side, and then I do an anastomosis. Before I do the anastomosis, I would have done the rectopexy so that the rectum doesn't fall back and it remains up when you do the anastomosis. The rectum must be straightened. That is why you have to mobilize. And rectosigmoid resection is better than sigmoid resection. So a little bit of the upper rectum will come. So it has combined advantages, usually with suture rectopexy, never with the mesh rectopexy. Recurrence rates about the same for all procedures. But it does have a mortality. Any rectal anastomosis can leak. And if it leaks, they may die. So you have to be careful. So prepare the colon and take all precautions to do the anastomosis. There is a definitely diminished postoperative constipation. A laparoscopic rectopexy has reduced pain, shorter stay, early recovery, and early return to work. So obviously, all these procedures can be done laparoscopically, and it would be better that we all started doing laparoscopic rectopexy. I firmly believe that it's a superior operation to open rectopexy. Now the key question, how much to mobilize? And this you will find different people giving different answers. But the key is that there is a posterior mobilization and there's an anterior mobilization. Virtually everybody agrees that the posterior mobilization must be to the levator ani muscle, up to the level of the levator ani, till you see the levator ani muscle. Because when you see that only, the lower rectum and anal canal straighten out completely. So you must go posteriorly right down to the levators. Anterior, to do or not? In a woman, it's a simple question. You do it because it doesn't affect sexual function to that great extent. So you do it. In a man, if the prolapse is more than 5 centimeters and you're doing an anterior procedure, abdominal procedure, you have to do anterior mobilization, and usually to the apex of the prostate. But if yours is a young patient, small prolapse, then you have discussed the point of impotence and is against having any chance of impotence, that is the only case in which you do no anterior mobilization. You can leave it and come up. And that again is up to the prostate or 5 centimeters from the lowest point of the rectouterine pouch, usually at the apex of the prostate. So I hope I'm clear about how much to mobilize. Posteriorly up to the levator ani. Anteriorly, young patients, small prolapse, no mobilization. Anteriorly, large prolapse, more than 5 centimeters coming out of the anus, you have to do an anterior mobilization. If the patient is not willing to, for the risk of impotence versus recurrence, then you do a perineal procedure and do a perineal proctosigmoidectomy, which may be the better alternative because that won't cause any impotence. So this is how I do rectal mobilization and rectal surgery in laparoscopy. My camera is on the right side of the abdomen. You see it's at the level of the umbilicus and it's around the mid-clavicular line. I put the camera here. My left hand operating port is at the umbilicus. My right hand operating port is just above the pubic, is just above the inguinal ligament, below the ASIS. And I have a left side retracting port which will retract the rectum. There's a close-up to show you the same view of the port. Is a mesh necessary in rectopexy? Recently, this is challenged. And now the results which have come show that suture rectopexy as good as mesh rectopexy. But many surgeons have got it into their head that they must put a mesh. A mesh can erode into the rectum. It can increase the constipation. I think we should not be using meshes anymore in rectopexy, but doing a sutured rectopexy. But I know many surgeons, including Palni, who don't agree with me, and they say that we will use a mesh. But I personally don't prefer to use a mesh anymore. For the last 15 years, I have not used a mesh. What about the lateral ligaments? Because they will come. In a prolapse, they are pulled and they are elongated. Now, people say that the lateral ligament division causes impotence. Now, if you divide the lateral ligaments away from the rectum, they won't cause impotence. It's only close to the rectum that the nervi irrigantes go via that area. So if you're doing it away, it doesn't. What it does do is that if you cut the lateral ligaments, they become constipated. And the long lateral ligaments, if they're left behind, they tend to cause more recurrence. So if you preserve them, the patient's continence is improved faster. The constipation will remain the same or may even improve. And division means that there is less recurrence. So what I do is I do a compromise. I divide fully the lateral ligament on one side, and on the other side, I just give it a nick so that it will move up somewhat, but not fully divided. So leaving some nerves coming from one side. So this is my usual practice. But if they are very long, very large, then I just unhesitatingly divide both lateral ligaments and I just go ahead and do the rectopexy. What are the outcomes? The problem in literature is the variation. You see all these and you see the percentages of the varying from 15 to 80%. It doesn't seem to make sense. But most studies now are showing results in excess of 80%. And we know that resection rectopexy improves constipation. Rectopexy alone, especially with a mesh, worsens constipation. There can be complications. While doing the abdominal procedure, you can have presacral bleeding. Now, when you have presacral bleeding, immediate thing is to try to do bipolar, try to do monopolar, and the bleeding will worsen because sometimes they'll retract into the gaps. So my advice is, if there is bleeding from that presacral veins, put in a pack, put a instrument to press, call your strongest assistant, ask him to press. You go out, have a cup of tea, have a snack, watch the TV for 10 minutes, and then when 15-20 minutes are passed, you come in. When you come in, you wash up and then gently remove the pressure from the gauze piece. Now, don't remove the gauze piece. Don't pull the gauze piece off. What happens is there's a clot which might have formed, and the clot will be adherent to the gauze piece. So if you pull, the clot will come and again it will start bleeding. So what you do is pour a lot of saline on top of the gauze piece till it gets nice and soggy. When it becomes nice and soggy, just gently shake it and take it out. Then it will separate from the clots and there will be no more bleeding. So don't panic if you have pelvic bleeding. Packing is a wonderful way of stopping bleeding. We have forgotten that in modern surgery. We keep thinking, I will use this, I will use that, I will use my sophisticated 20 lakh electrocautery. No. Simple packing is the best. If you put a mesh or foreign body, pelvic abscess can form. If you have resected, you can have an anastomotic leak, mesh infection, mesh erosion into bladder. As we already discussed, that sexual dysfunction, if there's anterior dissection, especially in males. In perineal approach, there is a high recurrence. As long as you're doing an optimized operation, there's no bleeding. But if you're trying to mobilize posteriorly to bring it down, straighten it out, just like you do anteriorly, that can lead to presacral bleeding because you're doing it from below, and some of it may be blind. And again, if there's any anastomosis, can have an anastomotic lead. This is a 2015 Cochrane review, 15 RCTs, and they showed that the perineal procedures were inferior to the abdominal procedures. No abdominal procedure was superior to one another. No perineal procedure was superior to one another. I won't talk about recurrent prolapse. Only one word of warning I want to give you about recurrent prolapse. If there has been a resection and anastomosis done before, you must remove the previous anastomosis. This is the only important thing in a recurrent prolapse. All other principles are the same. Now, why should you remove that anastomosis? Because suppose you do another anastomosis and division higher up, it is possible that this segment may get ischemic. And since the anastomosis is at the very end of the segment, it is more likely to become ischemic, and this may now lead to a perforation and leak, though it has been healed for so many years. So always remove the resected segment of the rectum and make sure that it is taken out. Some people have done robotic rectopexy. I have no experience. The results are similar to laparoscopy. Really no great improvement. Like most of robotic surgery, it is a forcing of an expensive operation onto the patient to garner more patients and garner more wealth for both the surgeon and the Da Vinci company. That has been my conclusion after seeing robotic surgery. I don't see particularly any great advantage unless you're doing a prostate where the anastomosis is difficult. And they say for a Whipple to reconstruct because they feel that it's easier to reconstruct with a Whipple. So these are the two places where it may be useful. But for the other routine operations like rectopexy, really no advantage of the robot over the thing. So in conclusion, young fit patients should have abdominal procedures. Laparoscopy has many advantages and should be used instead of open abdominal operations. And suture is as good as rectopexy. I will come out. I will play the video from outside.
So you're going to need to share your screen again.
Yeah, again, I'll do that. The problem is that this thing whole screen takes it's difficult to go back to the.
Just go to share screen, play your video and make it full screen.
Why am I not getting this the zoom? Wait, yeah, I have to make it full screen.
Yeah, and also just share your screen.
Share screen. And see, unless it is playing, it won't come.
You share your screen and then you can play.
Kanagwel, would you like to help out?
Ramesh, sir, can I give you some suggestions, sir?
Yeah.
Sir, you please share your desktop, sir.
Yeah, I'm sharing my desktop.
We are
Okay.
unable to see that, sir.
Okay. Can you see the desktop now?
Not yet, sir. Not yet.
Share your screen.
Yes, sir. We are just about to get sharing. Yes, sir. Sir, now you try to click the video on, sir. Yes, sir. We are able to see your video, sir.
Right.
Yeah.
Okay. Okay. So this is the port positions I showed you in the still, so that I don't have to show it to you in the video. And so as soon as I go in, this is a female patient. So the uterus will keep coming down. So this is one way of keeping the uterus out of the way. You take a 10 Prolene stitch from both sides onto the uterine cornus, taking the lateral ligament and the tubes below that, and hold the thing with a needle puller. And you know, when you tie it up, it just remains nicely retracted. So you don't have to sit and retract it. And what you will see is that as soon as we go, we will first see where is the right ureter. And you will see the right ureter there. And you will see the sacral promontory. That's the sacral promontory. That's and the deep pelvic pouch, which we normally see. We go a little more medially than compared to a malignancy, and divide the peritoneum reflection, and we will keep going down to do the posterior dissection. And you can see we go in the same mesorectal plane which we do for cancer. Previously we used to say we'll stay on the rectum, but that is very bloody, and this is much better staying in the mesorectal plane. And we can just go right down as far as possible, always keeping the ureter in view, of course. And you see the ureter is going there, and there's no ureter there in the peritoneum. And you can just cut that. And so you do from both sides, and the posterior dissection continues till you reach, as I said, the levator ani. So here you see a pelvic nerve. So because you stayed in the correct position, the pelvic nerves will be saved. And you see that this is a beautiful avascular plane that we get posteriorly. And you keep going right down till you have reached the levator ani. You will see it soon. There may be some small bleeders. You can just take them. And now, as you go there, you see the rectum is moving anterior. Now, this is a place where you will know that the posterior dissection will be ending. So you see this, the angel hair appearance in the posterior wall, which tells you that you're really near the levator ani level. You can see the pelvic nerves which are preserved completely. So that's a pelvic nerve there. And so nice here. So one pelvic nerve on this side. And this is the medial to lateral approach to safeguard the ureter on the right side. On the left side, sorry. So from here you look and you will see the ureter there coming. There you can see the ureter appearing here. And once you got the ureter, then you can open the pelvic peritoneum on the left side. And you will have the whole rectum mobilization. And one of the good things to do in laparoscopic rectal surgery is tell the anesthetist not to use nitrous oxide, because nitrous oxide will bloat up the bowel and then make life miserable for you. This is a female patient, so here we will do anterior dissection between the vagina and the so now on the left side, you incise the peritoneum and you enter into the gap which you have created. You will see now the gap has already been created this side. See that? And when you do that, you will find that the left ureter is taken away. The left lateral ligament has been divided. And we do anterior dissection. Here you can see between the vagina and the rectum by dividing at the lowest point of the recto uterine pouch, the recto vaginal pouch. So that recto uterine pouch. So at the lowest most point we do the division. So once we have done that, from there we mobilize for about 5 centimeters. So when you have done that for 5 centimeters, you will find that the rectum is now coming up. You see that? That's a vagina actually, rectum, and anteriorly is the vagina. And you see how we use the retractor to straighten the rectum. So that in the male, so this is another case I'm showing just to show that if you're doing how you can keep the nerve safe, that is to identify the seminal vesicles with the fascia on top. So the seminal vesicle is seen there. You see that's the seminal vesicle here. And so if you keep the fascia on top of the seminal vesicles, the nerva erigentus will flow away from that. If there is an anteriorly placed tumor of the rectum, you cannot do this. You will have to go in the plane anterior to the denon-Villiers fascia, and the patient will probably end up with an impotence. So you have to take permission before surgery, because there it is a question of life. Otherwise recurrence will come and then he will die. So you explain that to them and tell them that it will be impossible to save because it's an anterior tumor, and we will have to go in the plane between the denon-Villiers and the bladder and the seminal vesicles. So we have to divide those nerves necessarily, most probably. And you can see that the fascia covering the seminal vesicles is preserved in the male patient. So we have done it on both sides. And this patient had a large prolapse, so we had to do an anterior dissection. But he was 70, so when we explained to them, he said, it's okay, I'm not sexually active now. So he agreed to the procedure. He said, even if something happens, I don't mind. Then we will, then we come to the next procedure, which is the rectopexy. And I usually use 2-0 ethibond, and I take one lower stitch on either side from the lateral wall, taking care not to go into the mucosa, but taking a good bite of the mesorectal fascia and taking it on to the fascia over the sacrum. And then I take the ethibond, and like you saw, 3 throws are required, otherwise it becomes loose with ethibond. And we take it on the covering, connective tissue covering the rectum and the sacrum. So we have put one stitch on either side, then the second stitch this side, and this is where you have to be careful. You have to avoid ureter, and you have to avoid major the veins, and you take only the area where everything is free. Then we will take one to the stitch to the promontory, So this ethibond, the advantage is it comes as a 90 centimeter suture with the 2 needles on either side. So you can divide it into 45 centimeters each and use it as 2 sutures. So with 1 ethibond, we can finish off the 3 sutures. And so we safeguard the ureters and thing. And the last, and while doing this, the rectum is retracted straight out of the pelvis with a retractor on the sigmoid so that the rectum doesn't fall back. Okay, and now just this is the same suturing. One word about when you're doing resection rectopexy, we take care not to divide the inferior mesenteric artery. So the division of the vessels is done next to the wall of the resected part that we are going to resect. We let the inferior mesenteric artery, and as it goes to become the superior rectal artery, intact, so that the lower pouch, which is much longer than in an anterior dissection, has its own blood supply from the IMA and the superior rectal artery. So that is one thing that I am very particular about. I don't divide the IMA in a rectal prolapse, because if you do that, then you'll have to go much lower to do the anastomosis, and the lower you do the anastomosis, the more the chance of leak. So I don't divide that. I leave that, and then I can just keep the rectum at the level of the sacral promontory. I can divide it after mobilization, and it will be well vascularized. So this is the other side being taken. Now there are some people who will close the pelvis peritoneum from one side to the other side. I don't bother, because when I let it go back, it sort of fills the thing, and I'm not. So you see that we take on the presacral fascia, avoiding nerves and avoiding ureters. So that is important there. You must make sure both are avoided. In this stitch is where the most dangerous, because that is where the ureter crosses the iliacs, and you have to be very careful. And it has been pulled and stitched, so it will hold. And we give the patient a good preparation. I give them bowel preparation before surgery, and then after surgery, second day I start them on Primafin. So whatever motion they have, they'll have something, otherwise they will keep cribbing. So this side, again, you feel that, see that there is, you don't have to take on to the bone. You can just take on to the fascia. A periosteum is not needed, because all you need is that it needs to get fixed. It is not necessary to be permanently fixed, because the fibrosis will fix it permanently. So if you do like this, you see mostly the peritoneum is closed automatically, because we have not lost any peritoneum. So it just closes. So I don't bother to suture the peritoneum. I know some people take pains to close the peritoneum. I have no objection. I don't do it. And I'm not seen any obstruction because of that. So in conclusion, rectal prolapse has many solutions. And the reason that is there means that no solution is fully satisfactory. So whatever I tell is based on personal reading and personal experience. Young patients, I do abdominal procedures. Elderly patients, I do perineal procedures if they're not fit for anesthesia. And if I'm doing an abdominal procedure, I prefer to do a sutured rectopexy. If there is history of constipation, I will do a resection rectopexy with suturing, with the sutured rectopexy. I don't use the mesh nowadays. And the most common perineal procedure that I do is an Altmaier's proctosigmoidectomy. Thank you very much.
Thank you, Dr. Ramesh, for that very lucid and clear presentation and video. Let's field some questions. The first question is from Rajani. He is asking, what happens if you just leave a rectal prolapse untreated? So I'm assuming, what are the morbidities that you fear? And before you
So we have had patients whom I have seen 20 years back with a rectal prolapse, and I've advised surgery, and they didn't come back. And then now they come back in the middle of the night with the prolapse coming out. It has become engorged. It is not going back in. He is in severe distress. So then we admit him, and we put this local native treatment of putting a lot of sugar, raw sugar on that, and it absorbs the fluid, and hopefully it doesn't hurt you. Then we just do an Altmaier's proctosigmoidectomy. So the danger is of the prolapse is mainly, one is the incontinence. So it will keep soiling your clothes. So that's it's not a nice feeling, no? to sit and feel the wet cloth near your anus. I don't think anybody will be happy with that. The second is that it can the prolapse can become irreducible, and then that would be a problem. So I think a large prolapse, if you see a 2 centimeter prolapse, let's say 2 centimeters of rectum is coming out, patient is in no distress, I would follow the patient up. But if I see anything like 5 centimeters, I usually tell them that get it operated.
Maybe we can add to that chance of irreversible incontinence. As you mentioned, pudendal neuropathy left uncontrolled. Is that also a problem?
No, the pudendal neuropathy also recovers. The moment there is no longer a prolapse, the nerves are gone back. And you know that nerves, as long as they're not cut, that neuropraxia will disappear and they will recover, and they recover.
Question from, this is from Dr. Karthikeyan Mohan. He's asking, what is your personal opinion on a laparoscopic ventral mesh rectopexy? I think you
ventral,
yeah,
it's coming up in a large way, and from what I've seen from the studies, they require a deep anterior mobilization right down to the perineal body. I have not done any, but down to the perineal body. Now, women, which is where the Americans do a lot of these procedures, that's quite safe. But I told you, 90% of my patients are men. And if I do a dissection up to the perineal body in these people, a lot of them will be impotent at the end of the procedure. So I would not do this procedure for Indian males. If a female comes and she requires and it's also described more for internal procedentia than for external procedentia. So for internal procedentia, it's a good procedure. But when you have the whole rectum coming out, only an anterior mobilization, I don't think it will prevent the posterior from coming out. So I think posterior mobilization will also be needed. And then you can put a mesh to the anterior to pull the whole thing. But I have no experience. And because I have to dissect up to the perineal body, I've been reluctant to do it.
Maybe I can add to that. We've done a number of anterior ventral rectopexies. And as you rightly mentioned, the dissection anteriorly is aggressive. It's all the way to the perineal body, and we've done largely in women. In men, I think we're going to take your advice regarding counseling patients, regarding impotence, and then being selective. What is your take? You mentioned very clearly that you reserve a resection rectopexy for constipation.
Constipation, yes.
What if the patient is not keen about a resection? Especially when you explain to them the risk of not negligible leak and its attendant morbidity and mortality. What's your?
I tell them that you will continue to have constipation. You will continue to need to take your drugs which you are taking, some Dulcolax or Lactihep or something for your constipation. That will not improve by just doing a rectopexy. I can only prevent and the chance of recurrence is higher in a patient who has got constipation, because if he starts straining, then he is going to blow the sutures and bring it out. So I will explain to them all this. If they still want, then I will do a sutured rectopexy and come out quietly.
Any other questions? Sunil, you have a large experience in colorectal surgery. Would you like to touch upon something?
Ramesh, excellent lecture, excellent teaching, and very clear-cut take-home messages from you as always. Ramesh, are you aware of any randomized trial of posterior fixation versus anterior fixation? Because
no, I am not aware of any trial, but there might be. I have not looked up the literature in the recent past on this. The only randomized trial which I found out was about doing pexy or not doing pexy. This was from an Italian multi-center trial. But posterior was an anterior, I have not read. But I suppose if I search in the literature, I might find. If anybody else has found, they can tell.
Because it seems that the Western literature is kind of nowadays more in favor of ventral rectopexy. What do you think, Suviraj?
We look at the evidence in the the IAGS Indo-UK Surgicon, and I was part of a debate, resection versus no resection, and we touched upon this. If you look at the survey in practice, Europe is a big favorite for lap ventral rectopexy. Generally speaking, America was more for resection, but there's a shift now. they've, like Dr. Ardhanari mentioned, there's a move away since 2011 from meshes to more biological meshes in case you have to put in a mesh. Otherwise, a suture rectopexy is the go-to procedure. But they're now using meshes like permacol for anterior mesh rectopexy. The dissection purely anteriorly is all the way down to perineal body. You do a limited lateral, mobilization, not really taking off, both lateral ligaments, if not one, if at all. The posterior mobilization is very limited. I saw in another conference a surgeon do it. The key difference is that you actually repair the pelvic descent, which is very clear, pelvic ballooning on MRI topography.
So you have to do the levatorplasty. The levatorplasty is a very important part of the operation.
This is more of a pelvic floor suspension. You pick it up with the suture rectopexy. The mesh is left in a wavy fashion, not taut. Levatoplasty, again, I have not done, but there is a limited advice for
but they say that you should do it, it gives better results.
Yeah. So you suspend the perineal body to the sacral promontory in a manner of speech. And the recurrence rates are roughly the same if you look at the broad evidence. Again, there's no head-to-head comparison that I'm aware of personally, but there's a lot that we are learning now from recurrent rectal prolapse and how that can be prevented. So it's an evolving story, I think.
But I think the fact remains that much of these procedures came for internal prolapse. The internal prostatentia, which was detected on the MRI, cine MRI, or on the cine radiography, and then they found that this is causing the patient urinary problem because as it causes blockage of the bladder, and they had problems. So they started doing for the internal. So for the internal, there's no outside prolapse. So possibly this procedure is a good one. When there's a big outside prolapse, I don't know how well it works. I'm not done. But I won't say it can't be done because I'm not done. So I don't know. But technically, it seems that it may fail in a larger percentage.
Yeah,
the main attraction is that we avoid constipation. Yes. The main
because
sorry, sir, go ahead.
When we are doing the posterior fixation, as you have shown nicely, we are dissecting the rectum completely out from the sacral hollow down to the pelvic floor, and then pulling it up and fixing. Now, if you haven't done the posterior dissection, what you are pulling up is mainly anterior wall. So it will help only when there is a intussusception because of the anterior wall, anterior rectal wall. But if there is a definitely posterior rectal wall coming out, then it will not help.
So if it's a recto C, which is projecting into the vagina, that would be a very good procedure.
Yeah. Ramesh, you mentioned regarding all the procedures. I just want to have your opinion regarding recurrence after laparoscopic rectopexy. How do you proceed?
Yeah. So I have had 2 recurrences after laparoscopic rectopexy in the last 25 years. And in both of them, I decided to do I had done a mesh rectopexy. This is, I'm talking of long ago. So I decided to try laparoscopy. In both, I had to abandon laparoscopy because the mesh had caused so much fibrosis. I couldn't do any dissection. So then I opened up, mobilized the posterior thing, removed the mesh, and then I brought it out, and then I did a resection rectopexy with the mesh gone, and both the patients did well. So I think when you have a laparoscopic recurrence, if you have a mesh, it becomes difficult to do it repeatedly laparoscopically. But if you've only done a suture rectopexy, I think it is possible to attempt a re-laparoscopic rectopexy.
Yeah.
But I think this time, if you have had a recurrence from a plain rectopexy, I think you should go for a resection rectopexy.
Yeah. And would you consider going perineal way?
If there's there's a large prolapse, the whole thing has come out, then yes, perineal. But if there's a mesh is there, then the perineal rectosigmoidectomy is very difficult because the mesh would have been put right down to the base, and everything will be fibrotic. And you really have to cut that. It's such a mess to cut that mesh out. It gave me nightmares because I thought it would leak from wherever I've cut it, And actually, I sat and discussed for 10 minutes on the table with my PGs and my other consultants whether we should do an elective colostomy and wait. Then they said, we'll take a chance, sir. We put a drain. If there's any fecal matter, we'll immediately do a colostomy. So we took a chance and they got away with it. But I think that this is a nightmare operation if they put a large mesh.
Yeah. Excellent lecture, Ramesh. One last point, because it is related, though it's a separate topic, but regarding internal rectal prolapse or say obstruction defecation, how is your practice? You operate them?
Frankly, I see these patients. I refer to my friend Mark Jesudasan in CMC Vellore because I don't see them very commonly. So, and I know that they are difficult patients. They require a lot of workup, a lot of psychological counseling, and so I don't touch them. I explain to them that this is something I have not done much, and I don't want to experiment upon you, and I just refer them to a dedicated colorectal surgeon, because I think for that sort of complicated, what decision to take. You see, the procedure may be easy to do, but what decisions to take, that one who is interested in that topic only will do. And since I'm not that much well read in that area, my interest in colorectal is into malignancies and rectal prolapse. That's all. I don't even the other things I don't see much. I do ulcerative colitis, of course. We do less than the north. Our loads are less because the disease itself is less common here. But those I will do with laparoscopic resection. I know what to do. But this internal thing, I am not read it very much when I was a student. I have not been very much into it, and so I don't do it. I refer it to somebody who can do it better.
Yeah, thanks, Ramesh, for that honest opinion. Has any of these patients whom you have referred, have they come back to you with any further complaints?
No, they have not come back.
They go to
I think they go back there to follow up. I don't think they don't come back to. As long as Varghese Mathai was in Madras, I could send it to him also. When he moved to Hyderabad, it became difficult to send it to Hyderabad.
Yeah. Thank you very much, Ramesh, for a very lucid presentation and sparing your valuable time. I know you are an early riser and early sleeper, but thanks for sparing your time with us.
No problem.
And over to you, Kanagwal.
Thank you, Dr. Ramesh, sir, and thank you, Dr. Subiraj, for making this evening academically a very brilliant one. I'm sure every slide oozed out the experience and wisdom what has been acquired over 38, 40 years. I'm sure Dr. Ramesh would have done the earliest few rectopexies in the whole of the country, because I've seen him operating as early as 96, 97 onwards. I'm not sure who takes the credit of first rectopexy. I'm sure he has many first to his advanced laparoscopic surgeries from that part of the country. And
no, but rectopexy, I think I was not the first. I think Palli must have had done before me. I did it a little later.
So he has been always happy to operate across the country, and he has been happy to teach any of the youngsters. And also, I'm proud to share his surgical gastroenterology department is one of the most sought after. In spite of so many institutes coming up, you can see very high ranked students have joined us. And I'm sure it is one of the very few departments in the country where postgraduates are allowed to complete skin to skin on their own, which at least at this point of time appears the zenith of the surgical gastroenterology training. Thanks to you, Dr. Ramesh, for the trust who have kept on all the PGs. And you always believe any PG who is trained for 3 years should operate on their own.
Yeah, they're going to go out and be consultants. So we can't just give them a paper degree. We have to train them and send them out. That is my view. And I was fortunate to be trained like that at All India Institute and sent out. And that is what made me a complete 6 years there. So I was very, so I always believe that PG should not be used as just labor to draw blood and collect reports, but be given active chances in many ways. And there are ways to do it. And
the message for all the participants here is loud and clear. I'm sure with commitment from the trainer and the trainee, any surgery can be learned with passion. Thank you, Dr. Ramesh, for giving us a wonderful piece of advice now. And I thank Dr. Suviraj, who has been always updated and has done his homework and made his evening an enjoyable and learnable one. With that, I call this session a close, and I invite the Honorary Secretary to share his viewpoints and give the vote of thanks. Over to you, sir.
Thank you, Kanagavel. Thank you, President. Can you see my slides, Kanagavel?
Yes, sir. Very well, sir. Good to go, sir.
Yeah.
Dear President, my dear viewers of Top Plexus, I'm sure all of you will agree. Today we had two excellent back-to-back lectures on two common issues on the rear end of our problem. I think it was two excellent lectures, one from across from South America, Venezuela, Dr. Professor Ricardo, followed by our mentor and excellent orator, Dr. Professor Ramesh Ardhanari from Madurai, and we give them both hearted appreciation for keeping it a very interactive session. And thank you, Ramesh. And we have sent the soft copy of the certificate of appreciation to you. And on behalf of our AGS Central Office, we thank both our EC members from the North Zone, Dr. Subhash Agarwal, Dr. Suviraj John, for introducing the speaker, keeping it in a very interactive, firing the questions, and make it very useful points for all the budding surgeons. And from the Central Office, couple of information I want to share with all the viewers, especially our members. Of course, we have been going on for the online FAGS and EFAGS, the laparoscopic endoscopic fellowship programs for the last 16 months online because of the ravaging COVID. And false oncology is also, registrations are welcome. And you'll be wondering what happens once you finish all the modules. You will be ready to take the on-site assessment before we go in for the next convocation that's going to happen early February in Rajamundry. So one site for assessment for you all is to come to Sri Ramachandra in September. As you can see, we are planning to have a twin program, FAGS and also EFAGS in the same venue in two different places in this September. And thanks to Kanagavel and Dr. Balaji Singh there, they are doing the hosting of this. I'm sure all of you know how good the institute. I'm sure it will be both academic and a gastronomic delight to be there, both as a faculty and also as a delegate there. You're all welcome. And also, I think we are all moving on in the right direction. With probably we keep our fingers crossed with the COVID status, but I'm sure if things are favorable, we are going ahead with our false advanced laparoscopy program. The one early September in Delhi, false upper GI, thanks to I think Randeep Badwan is making all the preliminary arrangements, and the flyer is already on. So people, please start making the inquiries in this, Dr. Kanagavel and Dr. Randeep, start blocking our dates for this program. I think somewhere we need to come out of our cocoon and start mingling with the people, and that's the way the life goes on. And as you all know, while we are all fighting the COVID, we from the IAGS were doing our efforts in the social front, collecting close to 30 lakh rupees thanks to our vibrant academic association, also the COVID task force led by Professor Sunil Papat and Zamir Basa. We were able to do lots of activities across the globe, especially in Tamil Nadu, in Trichy, and also we've been more recently, we've been to the hill place, Valparai, donating close to 2 lakh worth of all these relief materials. And as you can see, we have supplied close to 35 oxygen concentrators. The last one, more recent one, is a 10 oxygen concentrator been supplied by the AMS India, one of the voluntary organization from USA. They are donating 10 lakh rupees to IAGS that we are going to deliver it, and that's going to happen. So please start pumping in. We never know where we need your help. The third wave, people are telling all about it. Be brave. And I'm sure with all of us vaccinated, we remain safe. I'm sure the better days are ahead. Till that time, till we meet in the next IAGS prime time. Thank you. Good night. Jai Hind. Bye-bye now.
Thank you, sir.
Thank you, Ishwar.
Thank you all the faculty. Thank you, President, for giving us this opportunity to host the prime time. I thank the Docplexus team for giving us all this platform. I thank all the speakers, Professor Ramesh Ardhanari, Professor Ricardo, Dr. Subhash, and Dr. Suviraj, Ishwar sir, President Sir, and the entire galaxy of delegates who have been with Docplexes, IAGS Connect platforms, IAGS channel, Facebook Live, and across the globe have been joining us for this evening. Friends, I'm sure we are going to have more exciting academics coming up in the next fortnight, and you will receive the information shortly. With that few words, I call this session a close, and I thank one and all for joining us this evening. Goodbye and good night.
Thank you.
Bye.
Good night.
Thank you.
Good night. Bye.